Thank you for that very comprehensive review of your group within FDA. So now we're going to hear from CMS and from Dr. Hartstein and Tamara, Syrek, Jensen. Are you going first? Okay.
Thank you. Thank you for inviting me today. I'm going to go over the coverage aspect for Medicare, and then Marc Hartstein will then go into the payment parts for Medicare. And we work very closely together, so they fit together hand in hand. I just wanted to start out with next week, next Thursday, July 30th, is the 50th anniversary for the Medicare and Medicaid program. And as we look back, I think you can see the foundation is still there. But there certainly have been a lot of large changes that have occurred in the Medicare program. And my part of this is the coverage process, and it actually is one of the original parts of the statute that was signed into law in 1965. But this part of it, the coverage process, as one of the updates in 2003, put very clear time frames, statutory time frames for the coverage process. So I'm not going to go into detail into this particular slide, but if someone were to ask for a coverage determination, it essentially takes us 9 months to come to a final decision. We issue a proposed decision in 6 months. We have a public comment period for 30 days, and then we will have a final decision 60 days after the last day of the public comment period. And that final decision is effective the date we posted on our website. And we, so far, since 2003, we have not missed a statutory due date. So once we open an NCD, there's no going back. We're going to make a decision one way or another. So this is our statutory construct. It's under 1862A1A, as I mentioned. And really what we do is we make a decision of whether a particular item or service is reasonable and necessary. And the way that we have operationalized that, so, well, let me back up. So Congress never defined reasonable and necessary, and CMS, while we have tried numerous times, have never put it in a regulation or anything like that, but we have operationalized it in our national coverage determinations. And essentially, it really comes down to, is there enough evidence that gives us enough confidence that this particular item or service is beneficial to our beneficiaries? So does it improve their health outcomes? And it was first used in 2000. We used it quite a bit in 2000. The coverage process, I think the paradigm really started changing in 1999, where the core of coverage determinations are really the evidence-based paradigm. And we first, as I said, used it in 2000. I believe this was for PET, but I think there's a variety of them in 2000. But this is for a diagnostic test, and it was for PET. And we've had numerous decisions since then. So just in a very, very high level, and I certainly can get into more detail in the panel, but this is some of the questions that we ask ourselves when we open up a national coverage determination. So key to it, because the foundation of any coverage determination is the evidence. So what is the health benefit? What is the outcome? Is there longer life with improved function? Does this mean you don't need to have any other medications? Or is there some quality of life improvement? We take all of that under consideration when we write our coverage determinations. And then we take a look at, as we take a look at all the studies that we review, we say, okay, how do we mimic what's in these studies to ensure success for our population? So is it a very specific patient population that we need to narrow our coverage determination? Is there some practitioner specialty that we need to narrow it to? And then is there a volume criteria that has made it a success? So we do take a look at all of that to see if we want to add that to our coverage determination as well. And then while we start with the evidence, and that clearly is the foundation of all of our coverage determinations, once we take a look at that, we also have to take a look at the law to see, okay, is there anything in that Congress has told us we can or can't do? So that may move the decision left or right, and look at precedent in our other coverage determinations. And then I think what is also very important is implementation. So how do we actually implement this? Because as you know, coding is an imprecise, it's a system, it's an imprecise system that may not have the exact code that fits the national coverage determination. So we have to do the best we can. And we have to take a look at our decision and say, okay, is there a way to tweak this so that it's easier to implement in the Medicare claims system? So we take all of that under advisement, and that is what you see in a final decision. But I just want to emphasize the basis or the foundation of any decision we make is always based in the evidence, and that's how we defend it. So I think in 1999 these were yes or no decisions, and I think as we looked at all of that, we all know not everything is a yes or a no. There's always, most of the things that we review, most of the technologies we review are somewhere in the middle. So what do you do with all of those if it's only a yes or no? Because if it doesn't hit your threshold that is clearly reasonable and necessary, it clearly does improve health outcomes, then it's a no. So what we've decided to do, or what we conceived around 1999, was coverage with evidence development. And that's where the published evidence base, it looks like that we have some confidence in there, but we need to put some parameters around it so that it reports back to us to ensure that this is actually this is beneficial to our population. And so with coverage with evidence development, what we did was I'm a little out of order, but what we did was through national coverage determinations, we put very specific criteria in there. And so your technology would either be paid for in a registry with some outstanding questions we have on the evidence, and we would look to the registry to answer those questions for us so that when we reconsider that NCD, we can make a decision as a yes or a no, or maybe there are some other questions that need to be asked, and so we may revise that. Or rather than a registry, we may pay for that item or service in a clinical study. And so we would put what type of clinical study we would be looking for, and again, we would outline the questions that we would look for to be answered within that clinical study. And the goal of that is not for CMS to publish anything from there. We really are looking to the private sector to publish various articles or to help us make that decision. So we a lot of times we work with the academic centers to see if we can get a lot of this published out there so that we don't have to do CED. We really can make that yes or no decision, or maybe remove the NCD at all because the answer is quite obvious and it would fly through the claims system. And then the other thing that I would like to mention, I think that CMS has always been very supportive, or at least in the last 20-some years has been very supportive of evidence development. So for example, the investigational device exemptions, which we heard a little bit about from the FDA, there's also some payment mechanisms through Medicare. So in 1995, we wrote a regulation that when FDA categorizes a particular device as a Category A or a Category B device, we can then, it is payable under the Medicare program. So we actually revised that particular regulation in 2014, and we fully implemented it in January 1st of 2015. So now anything that has been categorized as an A or B, the protocol now, the FDA-approved protocol, needs to come to our office. We will take a look at it. We have criteria in our regulation of how we're going, of the criteria that we're going to match it against to see if we are going to cover it or not. And if it is coverable, and we send you a letter saying yes, this meets our regulation criteria. For Category A devices, we can pay for your routine costs. For Category B devices, we can pay for the actual investigational device as well as the related and routine costs. And so we have started that as I said at the beginning of this year, and I think we're at 15 to 20 devices that we have approved, and they are all posted on our website. We're going to take another evaluation of this at the end of this year to see how this new process worked. Previously, it was all left to the MACs, our local contractors, and I think it's working better now that it's in central house because you'll have, in our central office, because you'll have the same coverage across the country. Secondly, in 2000, there was an executive order for us to encourage more Medicare beneficiaries in clinical trials. And so the way that we implemented that was through a national coverage determination in the same year in 2000. So what we have done there is similar to IDEs, although it's not limited to devices, that if you are a CMS approved trial, and really it's a qualified trial where if you are sponsored by one of our sister agencies in HHS, for example, NIH, FDA, ARC, then you are eligible to have your routine costs paid for in that clinical trial, as well as that investigative item or service in that clinical trial. So that's another way that we have supported evidence development. And then lastly, as I had described before, and we officially put a name in it in 2005, is that we have also created coverage with evidence development, which uses the same statutory authority as the clinical trial policy. And as we take a look at CED, we are still trying to see if we can make that more efficient, because an NCD is one particular item, one by one by one, and is there a better way and a more efficient way to do that so that it isn't one by one? So it's because that is a 9-month process. Another tool that we have used to help with evidence development to get more of these technologies to our population is collaboration. And so we have been working with the FDA, as I mentioned earlier, with investigational device exemptions, but also in parallel review. So we put a MOU for data sharing in place in 2011. And so we work with the FDA in sharing data so that we can review some of the evidence along with the FDA for our purposes. We each have our statutory missions, and none of these cross over. Since their authority is safety and effectiveness, ours is reasonable and necessary. But through parallel review, which is voluntary by the FDA, CMS, and the manufacturer, we have permission to review all of the evidence when appropriate at the same time. So we went through our first successful parallel review pilot, and we approved a colorectal cancer screening test, and the day that the FDA had issued their approval of that particular test, CMS was able to issue our proposed national coverage determination on that same day, and 60 days later, our final determination. And so we really reduced the time frame for the coverage determination by like 6 to 7 months, and that is unprecedented for CMS. I always say that I think I put the bar so high, I'm not sure I'm going to meet it the next time around, but hopefully we can. So, since you had a decision within like 60 to 90 days for a process that normally takes 9 months. And then we also are collaborating more and more with NIH. I think one of the more recent collaborations, or at least one of the more recent trials that we really based our decision on, was the National Lung Screening Trial. That is really the basis for our screening decision for lung cancer screening with CT. It was working with NCI and getting that decision out and talking with them, and that is the decision that you saw that was recently published this year. And then lastly, we also work quite closely with ARC. They write a lot of our technology assessments. They updated a technology assessment for us on peripheral artery disease, which we are having a MedCAC on Wednesday. So we use their TAs as places to start for our NCDs, or to do MedCACs to show if the evidence gaps have been filled, and so that the MedCAC can then can give us advice on the quality of the evidence that they're seeing. And ARC presents there for us with their TAs. And it's a way for us to stay arm's length away, for them to do an analysis, and for us to use those in our national coverage determinations. And then ARC is also our partner in coverage with evidence development. Our statute leads right back to ARC, and so we work with them on all of our coverage with evidence development national coverage determination, and so they have to approve all of the questions, the outstanding questions we have. ARC and CMS work together on that. So with that is just a very high-level summary of what the coverage group does. With that, I'd like to introduce Marc Hartstein, who is on the payment side of the house for Medicare. Thank you.
All right, good afternoon. So I learned something. Tamara's never missed a deadline. I wish I could say the same thing. Unfortunately, no. Just to set this up, Tamara and I do work very closely together. And one of the reasons we have to work closely together is because the way the coverage process works is the first step in the determination is a benefit category determination. So it comes to us first to determine whether there's a Medicare benefit category, then it goes back to Tamara to do any review of reasonable and necessary, which she described, then it comes back to me and my group to determine payment. There's really no point in doing a reasonable and necessary determination if the item or service doesn't have a benefit category. So what I've listed here are several benefit categories that are in the statute. Just as examples, there are many, many benefit categories in the statute, but 1861 S1, a very common benefit category for payment of Medicare services would be physician services. So anything done by a physician, as a physician is defined, generally an MD or DO, some other types of physicians. 1861 S2A, services and supplies, including drugs and biologicals, which are not usually self-administered, furnished as an incident to a professional service, are commonly furnished in physicians' offices and are commonly either rendered without charge or included in the physician's bills. This is probably one of the single hardest and most confusing statutory provisions to understand. I have been working for the Centers for Medicare and Medicaid Services, or its predecessor, the Healthcare Financing Administration, for 25 years, and I still have questions about what this language actually means. It has been the subject of much in the way of litigation over the years. It has been the subject of much fraud and abuse as well, and we are making some progress in recent years and in this year's proposed rule on trying to better articulate exactly what this is intended to pay for. So the first part is not too hard. Drugs and biologicals, which are not usually self-administered by the patient. So those are Part B drugs, typically chemotherapy drugs, drugs that the patient injects. Incident to a physician's professional service that are commonly furnished without charge. So this can allow the physician's staff person to be doing services, and we pay for those when we make payment to the physician for doing a service. We don't separately make payment for the services and supplies that are incident to the physician service. We recognize that in payment for the physician service, and then there could be other services that we do pay separately for. So for instance, drug administration. When a Part B drug, chemotherapy drug, is administered to the patient, we will pay for the administration of that drug under the incident to benefit. The reason it's under the incident to benefit is because it's not provided by the physician, it's provided by the physician's staff person, and there's a separate payment for the services of the administration. Another common benefit category is the hospital analog to the second point here, and that's 1861 S2B. Essentially incident to services in the hospital outpatient department. And again, what that's getting to are therapeutic services that are provided in a hospital outpatient department. Then this last category that I have listed here, like I said earlier, there are many more categories than just these categories. X-ray, radium, radioactive isotope therapy, including materials and services of technicians. I picked this one because this is about radiation therapy. And I do believe that this is where radiation therapy's benefit category comes from. So it's a therapeutic service. It would be covered, that would fit this description, X-ray, radium, radioactive isotope therapy, and it would be paid for under this benefit category, and it could be paid for in different ways, as I will illustrate in my upcoming slides. So some of the payment mechanisms would be the physician fee schedule. That's one big payment mechanism that we use in my group. That's used to pay for physician and practitioner services, so the services of the physician, him or herself. So surgical oncology, if operative procedures, that would be a surgical service. A physician service that would be paid for under the physician fee schedule. Incident to services that are not separately paid. I already got into this in a little bit of detail. We will pay for the Part B drug or biological separately as a drug or biological, and there's a specific payment mechanism for that. What this is for are for the incident to services that are not drugs and biologicals, such as the chemotherapy administration or other services that would be separately paid that are not performed by the physician, him or herself. I would like to say, though, that it's not, not diagnostic services. So, for instance, the technical component of a diagnostic service, like a radiology service, an X-ray service, the technical component of that service is separable from the professional interpretation service. We pay for the technical components service under the diagnostic services benefit. So well, I don't even know if it was the last point. It's under a different benefit category that's not listed here. The diagnostic services benefit, the professional interpretation would actually be a physician service because it's provided by a physician. Radiation therapy services would be another example of a service that would be paid for under the physician fee schedule when it's providing in a freestanding radiation therapy center, not in a hospital outpatient department. So if it's distinct and separate from the hospital outpatient department, it would be paid under the physician fee schedule. The physician fee schedule is there's a formula for determining payment. It's the sum of physician work, what the physician does, practice expense, the cost of the overhead, medical supplies, medical equipment, clinical staff. Then it's geographically adjusted and it's multiplied by a dollar conversion factor, and that gives you the total payment rate. So as I said here, data sources, physician work, estimates of the time and the intensity of the physician's work effort. Generally, this information comes to the Relative Value Update Committee, which is a committee of the American Medical Association, that multi-specialty panel that provides us with estimates of the physician time and work effort. Of late, there has been concern about the Relative Value Update Committee's involvement and recommendations to us for determining this portion of the physician fee, and so we've been looking for some different data sources. We've been working with several contractors, the RAND Corporation, Urban Institute, and others to come up with independent estimates of either time data or time and intensity of physician work effort. Practice expense also come from the Relative Value Update Committee. They're estimates of direct cost inputs. What we do is we combine them with these practice expense surveys that are done at the practice level. Or these surveys of physician practices that were done in 2000, I think 5 through 7. We combine these estimates as a very sophisticated methodology, and that gives you how much of the fee we attribute to practice expense. And then malpractice professional liability insurance, malpractice premium data is combined with Medicare utilization data and risk factors for individual services. So that, in a nutshell, is the physician fee schedule. I will now open another nut and give you the hospital outpatient prospective payment system. So these are for institutional services provided by the hospital. As I said before, Incident 2 therapeutic services. They're not paid separately, such as drugs and biologicals, so it's really just analogous to the physician fee schedule. Radiation therapy services when they're provided in the hospital outpatient department. The data sources for this quite a bit different. Hospitals report their charges on their claims. So they have what's called a charge master, and they decide how much they're going to charge for each individual service that they provide. They also report their costs in this very sophisticated accounting document called a hospital cost report. And then what we do is we merge hospital charges on individual claims with hospital costs at the cost center level. And then we determine, it's called a relative weight, which is multiplied by a dollar figure to become the payment amount. And we have different groups that we put together called ambulatory payment classifications. Each of those groups, we calculate what we call the geometric mean costs. So the relative costs of patients in that particular group relative to the cost of all patients across all cases, and that determines how we're going to pay for a given set of services that are provided in the hospital outpatient department. There are special payments for new technologies that are not yet incorporated into the data reported by hospitals. As you may expect, it takes a little while for us to get data from hospitals to be able to use in our payment system. So these cost reports, costs are accumulated over the course of a year. Cost report ends, the period ends, then there's some period of time where the hospitals get time to report it to the Medicare contractor, so 5 months. Then it takes time for audit and settlement of those cost reports, and then for that data to come to CMS. So it can take as long as 4 years for us to get the cost report data that becomes used in determining what we call the cost to charge ratio that's applied to hospital charges to determine our relative weights. The charges are on the claims. We receive the claims during the course of the year. After the year is over, we look at those claims to determine payment for the next year. Since there's a lag time between the time that the costs of a new technology are incorporated into the hospital's cost and the time we have that data in order to determine payment, statute and our regulations set up special provisions to recognize the cost of new technologies before it's incorporated into our data. One of these is right here. It's a special pass-through payment for new technology, not yet incorporated into the data reported by hospitals. So people can apply and they can say, we believe that this technology should be paid extra outside of what you normally pay because it's new. It's a substantial clinical improvement over what you're already paying for, and it meets the criteria for getting an extra payment. So this is where I always like to say Tamara talked about a couple of concepts. She talked about FDA, safe and effective. So I would view that as the lowest rung on the ladder. FDA is not going to approve a technology unless it's safe and effective for patients. So safe, which is obviously what it means, safe. It's not a hazard for patients to use that technology. Effective means that it works. Reasonable and necessary would be another rung up on that ladder, which would mean not only is it safe and effective, but it's reasonable and necessary, so it has clinical benefit to the patient and meets the criteria for Medicare coverage. Substantial clinical improvement would be yet the next rung up on that ladder, and what it would suggest is that it's better than what else is out there to treat that patient's condition. And the idea behind having substantial clinical improvement is we would pay more for something if it's better than what's out there. If it's not better than what's out there, why should we pay more for it? And then there's another special provision for a new technology group for new technologies that cannot be classified into an existing group. So we have 500 or so different groups. If those groups do not describe a particular technology, then we can create a new group called a new technology ambulatory payment classification group, and then those technologies can be grouped there in order to recognize the cost for payment. Drugs and biologicals, as I had said earlier, these are for drugs that are not usually self-administered or essentially injected drugs. They're covered under Medicare Part B. They're defined to include any drug or biological drugs and biologicals are defined to include those products that are listed in one of these resources, the USP, the National Formulary, United States Homeopathic Pharmacopoeia, or approved by the Pharmacy and Drug Therapeutics Committee of the hospital. So the data source for pricing drugs and biologicals is average sales price plus 6%. This is a statutory mechanism. We're required by statute to price drugs and biologicals at the average sales price. So the drug manufacturers report to us the price that they sell the drugs for to all payers, pharmacies, hospitals, physicians, etc. And then we accumulate that data, we calculate the average sales price, we add 6% onto that, and then that's what we pay to the physician who's administering these drugs. Radiopharmaceuticals, not covered by the average sales price statute, and the statute had directed us to continue paying using whatever methodologies we had in place in 2003, and those pricing mechanisms that we currently use are invoice, so essentially who's ever charging Medicare for the radiopharmaceutical would submit an invoice price, so whatever they have on the invoice from whomever furnished them the drug to Medicare, and then Medicare would pay that invoice price. There has been some concern about that of late because the sequester does apply, which means the sequester reduces the payment for the invoice price below what the purchaser actually paid. And then average wholesale price. Average wholesale price is 95% of average wholesale price. So wholesale price would be the price that's reported in pricing compendia, which may or may not be the price that a particular physician or hospital pays to receive that drug. In fact, it was this payment mechanism where people put inflated prices in these pricing compendia that caused Congress to pass the law to move to ASP plus 6, average sales price plus 6%, because of the concern that inflated prices were put into these pricing compendia, and then we paid 95%. We still do pay 95% of average wholesale price in the circumstance where there is radiopharmaceutical pricing, and that's the way we paid in 2003. And I think that's it for me, and I guess we're going to have a panel discussion.